Hello and welcome. My name is Faraz Al-Badarian. I'm a cardiac imager at Cleveland Clinic, Abu Dhabi. It is my pleasure to welcome you to this episode of ASNC interview series. My co-moderator for this session today is Dr. Vasvi Singh from Midwest Heart and Vascular Specialist in Kansas City, Missouri, where she is the head of cardiac imaging and the director of Cardiac Amyloidosis Center. Today, we're very excited to discuss commonly encountered artifacts with SPECT myocardial perfusion imaging. And our guest is none other than Dr. Gordon Dupuy, professor of radiology at Columbia University and professorial lecturer at Mount Sinai Icahn School of Medicine. Dr. Dupuy, Dr. Singh, welcome to this session.
Good morning.
Thank you.
Dr. Singh, do you want to kick off this conversation with a couple of questions for Dr. Dupuy?
Of course. Dr. Dupuy, thank you so much for joining us. So to start with, could you please provide us with an overview of sources of image artifact with SPECT imaging?
Of course, it's very important to recognize image artifacts because they create false positive studies and create unnecessary downstream cost. There are several sources of artifacts. First is instrumentation problems, and this includes flood field non-uniformity, center of rotation errors, and camera head misalignment. These are the job of the technologist, but the nuclear physicians are ultimately responsible for this and need to be sure that these things are being done and in some circumstances review them themselves. Secondly, there are patient-related artifacts, and these are perhaps the most common. One is patient motion, which can occur in the vertical or X direction, the Y direction horizontal, and also rotationally. And it's very important for the technologist to make sure that the patient is not moving and for the physician to recognize when there is patient motion. A big problem we have with our current tracers is tracer accumulation in tracer-avid structures, namely particularly the liver, the stomach, and the small bowel. And if these structures are adjacent to the inferior wall of the left ventricle, we can have scatter artifacts with increasing counts in the inferior wall, and we can also have the ramp filter artifact. Also, regarding patient-related artifacts is soft tissue attenuation, which we're all very familiar with. We have breast attenuation, we have diaphragmatic attenuation, and we have attenuation by the left arm if it's down. It's important for the technologist to try to keep these attenuators in the same position and make sure they're not variable. So the left arm is down in one position or the other, or the breast is more pendulous or up in another acquisition. Another source of artifacts is image processing. We relegate this task generally to the technologist. The technologist needs to make sure the axis is selected correctly, the radius of search from the center of the ventricle out to the epicardial border is correct and consistent. And also, it's important that we correctly select the base of the left ventricle. It is very foolish for a physician to try to interpret a study without first checking the image processing parameters, because if these are erroneous, we can create false positive studies in terms of fixed defects as well as reversible defects. And then finally, there are non-coronary artery disease problems that will create image abnormalities. They're not artifacts, but they're abnormalities. One we'll talk about later is left bundle branch block, where we may have fixed or reversible septal defects. Another common one is a short muscular septum or long membranous septum that can create what appears to be fixed defects at the base of the septum. Apical thinning occurs. We know that occurs in probably about 15% of patients from CTCA data, and this can very easily mimic a apical perfusion defect. Because of the lower count density resting images, our resolution is poor, and this defect can look reversible. It's very dangerous. We know about the RV insertion, the anterior RV insertion, and the inferior RV insertion that creates anoroseptal and infraseptal defects. Don't misconstrue those as real abnormalities. And for me, the most difficult one is left ventricular hypertrophy. It's very, very tricky. The septum becomes hot because the septum is thicker with LVH. And so the image normalizes to the hot septum, and the remainder of the ventricle looks abnormal, the anterior wall, the lateral wall, and the inferior wall. And it looks like the patient has severe multivessel disease. And unfortunately, the septum can be hotter in the stress images, and these perfusion defects appear worse at stress, and they look reversible. It's a difficult artifact, and you need to be aware of the patient's history of hypertension and any electrocardiographic evidence of LVH. Thank you.
Thank you for such an excellent overview. Another important question, what quality control methods are practiced to prevent or detect flood phantom or detect the non-uniformity related artifacts?
I would encourage all of our audience to read the SPECT guidelines. This details them very adequately. We want to do a flood field on every camera every day. So if you have a 3-headed detector, that's 3 flood fields on that camera. This is important because you can have defective photomultiplier tubes, and this can create very significant artifacts. Also, we want to do periodically a center of rotation. Back in the old days, we did this every week. Now with more stable cameras, probably monthly, but follow the manufacturer's recommendation. And lastly, you want to make sure there is no camera head misalignment if you have variable angle detectors, if the detectors aren't cemented together. And this usually is done periodically by your camera service person. But make sure these are done. And again, the physician is ultimately responsible for the study. So just don't relegate this to the technologist or the serviceman and pay no attention to it.
Thank you.
This is fantastic, Dr. Dupuy. Thank you so much. When you first start on evaluating a SPECT perfusion study, can you walk us through what is your systematic approach that you take, and what clues do you look for, and that would make you anticipate that, okay, an image artifact is going to be encountered and I need to pay additional attention?
Okay, first and foremost, by far most important, is to look at the rotating planar projection images in every patient. This means that it's inadequate to review a study on PACS, which generally does not have that, or on your iPhone. You really need to do this on the imaging console. When you look at the rotating projection images, there are many things, we've already talked about these, that you can see. First, you can look for just flood field non-uniformities. These will show up on the planar images as like holes in the image. Secondly, you look for patient motion. You look for patient motion in the X direction and the Y direction. Y direction motion is easy to detect. X direction, a little more difficult. You really have to look very carefully about this. In fact, in that case, it's always good to go look at the image sinogram, which also is available as a quality control measure. So certainly you want to do that. Then when you look at the rotating projection images, you want to look for attenuators. You want to, does this lady have a large, dense breast? Where is the breast? Is it up anterior over the anterior wall? Is it more medially over the septum, or is it a pendulous breast over the inferior wall? And importantly, is it in the same position at stress versus rest? Because if it's not, you can get a reversible defect. You want to look at the position of the left hemidiaphragm. Is the diaphragm very high up? And if so, you can anticipate a diaphragmatic attenuation artifact. Is there subdiaphragmatic activity? Where is it? Is it in the stomach? If so, you want to give the patient more water to drink and clear that out. Is it in the liver, particularly the left lobe of the liver? And in that case, you want to wait, delay your imaging for another hour. So look for subdiaphragmatic activity. You also will look for the left arm. Is the left arm down? Where is it? Is it over way back behind the posterolateral wall? Not going to cause a problem? Or is it over the more anterior aspect of the heart? Is it in the same position at stress and rest? These are all things that you want to look at in the rotating projection images. Also, you want to look for extracardiac activity. Does the patient have a lung mass? Does the patient have a breast mass? Something like that. Then, as I mentioned before, you can look at the image sinograms if you suspect motion problems. And then you always want to look at the processing of the study. Generally, this comes up automatically. Look for the axis that's selected. Look for the base that's selected. And when you finally look at your tomograms, make sure that the tomograms seem to be aligned. In the vertical long axis, you want the apex both pointing directly up at 12 o'clock. The vertical long axis, the horizontal long axis, you want the axis pointing directly up. In the vertical long axis, you want to make sure that the inferior wall is horizontal and consistent between stress and rest. So these are things that you just go through automatically before you even think about looking at the processed tomographic images.
Thank you so much, Dr. DiPieri. The next question, and a very common one, and you alluded to this a little bit earlier, when faced with a study with significant soft tissue attenuation, such as from breast or from diaphragm or significant GI activity, what to do next?
Well, what you need to do is anticipate these problems from the onset before you even image. And this is, of course, a lot up to the technologist. But if you have a very large patient, you're going to get a lot of soft tissue attenuation, decreased counts, and a poor quality study. You have two options. One, you can increase the dose to the patient. If you increase the dose, just be sure that you still maintain a 3-to-1 stress to rest ratio. So if you increase the dose from 10 millicuries to 12 millicuries at rest, you want to make sure you increase from 30 to 36 millicuries at stress. Okay, so you can increase the dose. But of course, we're very cognizant of the radiation dose limitation guidelines. So instead of increasing the dose, it would be a better idea to increase the acquisition time if the patient can tolerate it. So instead of doing a 12-minute resting acquisition, do an 18-minute resting acquisition. This increases your counts by 30%. Very easy. So anticipate it in the larger patients. Also, if you have a patient who has large breasts, be very sure that the breast is in the same position at stress versus rest. Make sure, and how do you do that? Make sure that the patient is, let's say, not wearing a bra. I prefer the patients not to wear a bra, both at stress and rest. Bra on, bra off, you're going to wind up with a change in position. The same thing, you want to make sure that the left arm is elevated to the same degree, because if the patient elevates her left arm way up over the head, the breast will be high. And let's say in the resting acquisition, or the stress acquisition, the arm is relaxed, the breast moves down, and you get a shifting artifact. So anticipate these problems. This is generally a problem with a lady with a small breast. And also the diaphragm generally does not shift between stress and rest. So that's not a problem. But breast and left arm, make sure they're in the same position.
Excellent. This has been a great discussion. Dr. DiPieri, the term hurricane sign is commonly heard in the reading rooms and among nuclear cardiologists. Can you explain to the audience what does this term mean, and what actions do you take if you encounter this type of image artifact? Try to fix it and remediate.
Well, what the hurricane sign is, it looks like a rotating low pressure area. It looks like the heart is sort of swirling, and there's defects in the opposed anterior and inferior walls. The cavity is oblong rather than round, and there's these sort of like streamers of activity extending off the edges of the defect in the anterior and inferior walls. And the most common cause of this is patient motion in the Y, or in the vertical direction. And what happens is, and I'll try to, my hands are here, the patient is located at one point during the first part of the acquisition, and the data are back projected into a central point in the reconstruction matrix. And then the patient moves, and now the data are back projected differently. And so the sort of the beginning and the end of the acquisition are sort of misaligned, and you can create this so-called hurricane. So if you see this, you don't want to deal with it. If it's, you might try to motion correct the study if the patient's already gone. But if it's such bad motion to create a hurricane sign, you want to be sure that you reacquire the study and try to make it so the patient does not move. You want to talk to the patient. You might even want to lightly sedate the patient to prevent motion. Usually it's due to discomfort or anxiety. One thing that you have to remember that will also create the hurricane sign is two things, actually, is a center of rotation artifact and also camera head misalignment. It'll create an identical artifact, again, because the data are being back projected differently from the first part of the acquisition to the second part of the acquisition. This is a much less common cause of the hurricane sign, but you've got to remember it.
Thank you. So the next question would be, left bundle branch block is a common source of artifact with SPECT. Why does it happen, and how should one minimize it?
Okay, you may have left bundle branch block probably due to a structural abnormality of the heart. And in this case, you will see that usually the septum is, the muscular septum is very short and the membranous septum is very long. The septum actually looks anatomically thinned and has decreased count density. And I don't think this has been well evaluated, but we see this, you have a patient with left bundle branch block, and, so many times they have that kind of pattern. Well, that's a fixed defect. And, obviously you have to make sure there's not infiltrative disease of the septum. But the one that is more problematical is one that occurs at increased heart rate. What happens is with left bundle branch block, there is dysynchronous contraction of the heart. The septum contracts, and then there's a delay in contraction of the lateral wall. And remember, the coronary arteries fill during ventricular diastole. And basically, the two sides of the heart are out of sync in terms of coronary artery filling. And the septum sort of misses out on its big chance for diastolic filling of the coronary arteries. Okay, so there actually is a very slight decrease in blood flow to the septum with left bundle branch block, but at low heart rates, at normal heart rates, we really can't appreciate that very much. However, at higher heart rates, this dysynchronous contraction occupies a larger proportion of the R-to-R interval, and the relative decrease in septal perfusion becomes greater. So at high heart rates, the decrease in septal activity is more than it is at low heart rates. So if you do a resting study with left bundle branch block, you probably won't see anything in the septum, maybe a little bit. But at high heart rates, the septal activity will be even less. So therefore, it looks like a reversible septal perfusion defect. Okay, so what's the clue, or what's the solution? Don't increase the heart rate when you stress the patient, which means don't do exercise, don't do dobutamine. You want to do pharmacologic stress, dipyridamole, adenosine, or regadenoson. But even with these agents, particularly regadenoson, the heart rate may increase during pharmacologic stress. Either the patient's nervous or it just does. And you have to watch out for that. So even when you do a pharmacologic stress study, always observe what the peak heart rate is. And generally, if it's less than 100 during pharmacologic stress, you don't have anything to worry about. But if you have that unusual patient where the heart rate goes up to 120, even with pharmacologic stress, you've got to worry about this reversible septal perfusion defect.
Thank you.
Outstanding. Now, Dr. Dupuy, sometimes artifactual defects are inevitable, particularly with SPECT. If you encounter such a defect and you feel that this is going to affect your ability to provide a definitive interpretation, what alternative modalities do you usually resort to or consider to fix this situation?
Well, one of these, I think these are more patient-related problems that you're referring to, and particularly like soft tissue attenuation artifacts. In that case, before we talk about alternative modes, remember increasing the dose and increasing the acquisition time. I think those are both very good proactive things to do. I am a huge fan of attenuation correction. We use attenuation correction, and you may have some patients with high hemidiaphragms, obese. You do a study with attenuation correction, no problem whatsoever. So certainly if you have attenuation correction, you want to use it. Low-dose X-ray attenuation correction is a lot better than gadolinium line source attenuation. So, but if you don't have either of these, certainly you would consider doing a PET study on the patient. PET, of course, has a 511 keV photon, so it penetrates the soft tissue a lot more effectively, and also there is inherent attenuation correction to PET. So PET is very helpful in getting around a lot of the attenuation artifact problems, which are probably the most common ones that you want to deal with. If you have a patient who really cannot stay still for an acquisition, really is not going to be able to stay still for that long period of time, you might consider a stress echo, or you might consider a CTCA. I mean, still you have a problem with patient motion, but it's not as problematical as the long acquisition times that we have with SPECT. But I think most of these issues can be dealt with by optimizing your SPECT study, either by increasing dose, increasing acquisition time, doing attenuation correction.
Thank you. It's been an absolute pleasure learning from you, Dr. Dupuy. One final question. So what is the impact of image artifact on accuracy of SPECT and downstream clinical care?
Well, of course, with artifacts, they generally will create false positive studies. So if you have a positive study, it generally is the burden of the referring physician not to leave things hanging. And so she or he will send the patient for a CTCA or even a diagnostic cardiac cath. And of course, this delays definitive patient care and also incurs expense. Also, even if they decide to just say, well, I'm not going to go ahead and do a cath, let's just treat the patient medically. Well, of course, this is the expense of increased medical care. So this is the downstream cost business, but there's also downstream cost to the physician and the laboratory as well, because the referring physicians will lose confidence in the lab and the referring physicians. Oh my God, another false positive study, from Dr. Jones. I just can't send my patient to that lab anymore. And so your reputation as well as your revenue is going to decrease if you have constant false positive studies.
Absolutely. Well, thank you so much for your valuable time. We truly appreciate it.
Well, it's my pleasure. It's really, I think this is a very valuable resource for the nuclear cardiology community, and I hope they will develop some increased skills as a result of the program. Thank you very much for inviting me.
Thank you so much. And on behalf of my co-moderator and the entire ASNC Education Committee, I would like to thank Dr. Dupuy for this very informative interview and thank our audience for joining us. Until we meet again on another episode of ASNC Interview Series, this is Firas Al-Badarin, and I wish you a very lovely day and goodbye.